Good evening, everybody. I'm Dr. Alvin Dondo. I'm a pediatric neurologist from Cape Town. I just want to welcome everybody to this webinar. It's one of the ILAE epilepsy webinars, and we've got a special speaker today that will be taking us through, and the topic for today's webinar, for tonight's webinar, is epilepsy and movement disorders. So movement disorders and epilepsy, and the speaker is Professor Shanez Tricky. She is a pediatric neurologist from Tunisia. She comes from ESFEX Medical School. She's the head in child neurology there. She's also the director of the research unit at the ESFEX University. She's also the director of the master degree of epilepsy, which she founded at the ESFEX Medical School, which currently is running an e-learning program. She's also the chair of the Eastern Mediterranean Regional Committee of the IBE. She's also president of the Tunisian Association Against Epilepsy. She is very well read and well written and well published in the field of epilepsy, which is her special interest. She is a huge advocate of dissemination of information and knowledge about epilepsy throughout the world. And she's got beyond 60 to 70 publications, and she's also in the editorial board of the Journal of Pediatric Epilepsy and the other journal of the Middle East Commission on Epilepsy. She will be taking us through the talk, but just before we start, and she starts the talk, which will be recorded, just to introduce some of the other panelists that will be in attendance. After the talk, there will be a Q&A session, which will be directed at Professor Tricky, but the panel will deal with those. And part of the panel is we've got Professor Samia Bensassi, who is also from Tunisia. She's a pediatric neurologist and head of department in her center. We've also got Professor Al-Hamdi, who is from the Middle East, from Riyadh. He's also a pediatric neurologist, and in Saudi Arabia, he'll also be part of the panel. So all of us will be involved in the panel after the talk, and we will address any of the Q&As that will come through. Just to plead with everybody to make sure that as the talk goes on, put your questions on the Q&A, and they will be addressed at the end of the talk. Welcome again to the webinar, and hope you enjoy it. And just to thank the League and the board of the League, and especially Jessica, who sent the invitation to all of us. And thank you. Hope you enjoy. Up to you,
Thank
Professor Tricky. You can start.
Thank you very much, Professor Nando, for this kind invitation presentation. And please, Jessica, you can send the video. Good evening, everybody. And first of all, I would like to thank the Eastern Mediterranean board member for their kind invitation and for giving me the opportunity to be with you today and to speak about a very frequent subject in child neurology, which is association and the distinction between epileptic and non-epileptic movement disorder, and also for giving me the opportunity to be a part of ILAE Eastern Mediterranean and Africa educational webinar program. So during my talk today, I'm going to speak about the best way to make a diagnosis and to differentiate epileptic and non-epileptic movement disorder. And then I will give you some clinical situation, some example of clinical situation when the movement disorder is isolated, and a more complex situation when the movement disorder and epilepsy are associated in the same family or even in the same patient. And as Jean Ecardy said several years ago, all that shakes is not epilepsy. And it is really true. And in order to make the distinction between epilepsy and no epilepsy event, we needed to have a very strong and clear diagnosis approach. But let me first give you a short reminder about the particularity of abnormal paroxysmal abnormal movement. Abnormal paroxysmal movement are characterized by intermittent attack of movement, and this attack of movement vary in circumstance of occurrence, in the time of onset, and also in duration. And we know that also the paroxysmal movement, but also epilepsy, are very frequent in children, and especially in children before the age of 2 years, which then can increase the difficulty of the distinction between epileptic and non-epileptic abnormal movement. And also paroxysmal movement of the same phenomenology may be of epileptic and non-epileptic origin. Indeed, in epileptic seizure, abnormal movement are frequent. It is present about 16 to 100% of children with epilepsy. Whatever is the type of epileptic seizure, it can be focal, generalized, or unknown onset. Motor symptom is very frequent in epilepsy, especially in children. But in the other hand, also movement disorder are frequent in non-epileptic seizure, especially in infant. And in the Shen and collaborator study in 2015, they determined the symptom, the clinical symptom of non-epileptic seizure. And they demonstrated that motor symptom is more frequent, the most frequent symptom in non-epileptic seizure. It is noted the abnormal movement are noted between 60% to more than 70% of children with no epileptic seizure. This situation is responsible of misdiagnosis of epilepsy in 20 to 40% of patients, but also it's responsible of misdiagnosis of refractory epilepsy in people with epilepsy. Confusion between epileptic and non-epileptic movement disorder is easy and due to several features. The first cause is that both movement disorder and seizure display abnormal movement with an overlapping phenomenology. The second cause that some type of movement disorder are associated with Eeg abnormality, such as paroxysmal nonconcentric dyskinesia associated with DC5 mutation. And also some type of other movement disorder respond very well to anti-seizure medication. And the best example is myoclonus with benzodiazepine and paroxysmal nonconcentric dyskinesia with carbamazepine. And the third cause is that in the same family and even in the same patient, we can have the coexistence and association of movement disorder and epilepsy. And the best example is autoimmune encephalitis, neurometabolic disorders such as mitochondrial disease, the genetic developmental epileptic encephalopathy, and also primary paroxysmal dyskinesia, which associate paroxysmal dyskinesia with ataxia, migraine, and also epilepsy. And in our clinical practice, we need to the distinction between epileptic and non-epileptic movement disorder is very difficult, and the cause of misdiagnosis are multiple. Indeed, the description, the precise description of the phenomenology of movement can be very difficult, and parents have difficulty to describe this clinical sign For them, all the movement disorder are the same, and all the movement disorder are tonic-clonic, and it's difficult to have an accurate description of the type of movement from the parent. This is why we need to ask this parent to, if they have a video, a home video, when the child or have this paroxysmal event. It can help a lot during our outpatient consultation. Also, fortunately, now the parents are aware about this possibility, and frequently they come to the outpatient consultation with their home video. Difficulty also on clinical examination. It is a paroxysmal event, and the duration of outpatient consultation is not sufficient to have, and sometimes we cannot have this movement during the consultation. And also for child under the age of 2 years, the movement disorder are variable and peculiar, and the distinction between the type of movement and a good description and an accurate description for the type of movement disorder is not very easy. And frequently we need to review patients several times, or to ask for home video, several home video, and also home during the inpatient hospitalization in order to have an idea, a better idea of the type of this movement disorder, or about this paroxysmal event. Also, and as I said, the same movement phenomenology can be seen in epileptic and non-epileptic seizure. And also for epilepsy, the evaluation of the state of consciousness and the post-ictal signs and all, or the aura for a diagnosis of epilepsy is very difficult in children. Another cause of misdiagnosis and very important cause is the over-interpretation of Eeg. Indeed, in this work, Benbedis and Cole found that false paroxysmal epileptic abnormality are noted in 25 to 30% of Eeg of patient diagnostic with epilepsy. So this is a kind reminder for a physician to have a special training or for Eeg pediatric before to begin to interpret Eeg, and to know that interpretation of Eeg in children is not too easy. And this is a good example to show the difficulty to have to make a distinction and to have the right diagnosis. This is a 5-month-old boy with a normal pregnancy. He has, unfortunately, a neonatal asphyxia, and he developed a tetraplegia.
Good evening. I think we have a bit of an interruption in
or clonic movement in the lamb arm, but also in the trunk. And this movement are triggered by intermittent light stimulation. And according to this clinical symptom, the diagnosis of myoclonus status was made, and the patient was treated by Valproate, but without any improvement. And if we see the Eeg of this child, we can detect, noted that in this in the movement recorded in the EMG, we have a paroxysmal event in the Eeg, which are described and interpreted as spike and discharge of a spike and polyspike. But if we change the time scale from 20 seconds per page to 10 seconds per page, we can note that this muscular event are not looked with paroxysmal abnormality, epileptic paroxysmal abnormality in the EEG, and this is there is no spike, but we have a muscular artifact. Also, and especially in some countries, the insufficiency of the EEG technology can be causes of misdiagnosis between epileptic and non-epileptic seizure. And we need, in some time, we need other electrophysiologic technique such as video coupled with EEG or EMG coupled with EEG. And this is an example of EEG coupled with the EMG in order to determine and to confirm that myoclonia has a cortical origin. And when we are lucky, we can have a discharge, EEG discharge or spike discharge, follow it by 20 to 40 milliseconds by a discharge, and a myoclone is recorded in the EMG. And this is seen at the cortical origin of myoclonia. But sometimes we cannot find synchronized jerk, locked spike or spike slow wave in the EEG. And in this situation, we need to have more and better electrophysiologic technique, and we can use jerk locked back averaging. And in this method, the EEG is averaged around the myoclonia. And if we have a focal discharge, a focal positive and negative spike, we can like in this figure, we can confirm that this myoclonia has a cortical origin. To have an accurate diagnostic of epilepsy is important, and I am sure that you know the importance of an accurate diagnostic of epilepsy. Indeed, false diagnostic of epilepsy is responsible of psychosocial consequence and stigma, especially in the children. And when the children has the diagnosis of epilepsy, he will be a patient with or a person with epilepsy the whole life, and this is not very comfortable for the future of this child. Also, a false diagnosis of epilepsy can deprive the child of having treatment for curable pathology, and also can deprive the family of the possibility of genetic counseling. Also, a false diagnostic of epilepsy is responsible of the use of unnecessary treatment, which can be responsible for serious side effects, sometimes deadly. And also in children, they also can be responsible of learning disability and the school failing. And also the use of unnecessary treatment noted in between 20 to 70% of patients in Kotagal study lead to the increase in the cost of health by the multiplication of the unnecessary exploration. So it's important to make the distinction and to make a right diagnostic of epilepsy to avoid all these disadvantage for for the people. This is why we need to have a good and a strong diagnostic approach. And the diagnostic approach, we have need to start with a very good history, phenomenology of the movement, and we need to ask about the personal and family history and to look after the presence and the existence of epilepsy, movement disorder, migraine, also to have an idea about the motor and cognitive development of the child, the age of onset of this movement disorder or this event, the circumstance and the time of occurrence, and also a detailed description of the movement. Neurological, somatic, EEG, but not the standard, only the standard EEG. We need to have EEG coupled to video and EMG when it is possible, or also mandatory in order to be able to make the distinction between epileptic and non-epileptic movement disorder. And don't forget that we need some time to re-examine the patient, and don't hesitate to re-examine the patient and to question the diagnosis if you are not very comfortable with the diagnosis of movement disorder of epilepsy. Better than we start a treatment or start a treatment which can be can harm these people. So now I will give you some example when the difficulty of diagnosis in situation when we have an isolated abnormal movement. And I will start with the frequent situation, very frequent in newborn, but also very frequently diagnosis as epilepsy. And this is the case of this newborn baby, referred to our department for with the diagnosis of focal clonic seizure. And the EEG video showed that the baby during the sleep have some clonic movement on the left leg, and this is a classical type of benign neonatal sleep myoclonus, which is characterized or defined as a paroxysmal jerk myoclonus, occurring typically occurring in two sides and synchronous, but focal predominance with lateralized jerk can be observed, such as in our patient. And this myoclonus tend to occur during at sleep onset and immediate cessation with arousal. And it's sleep myoclonus occur in the first 2 weeks in the baby with normal examination, neurological examination, and normal EEG. Another example of abnormal movement who frequently misdiagnosis as epilepsy is the shuddering attacks, which is determined or defined as a fast, rapid tremor of the head and with abduction in the arm and the knee, lasting a few seconds and repeated several times per day. And usually this movement, we observe this movement after with excitement or fear, and in a very normal baby with normal development, normal examination, and normal EEG. This is a situation shuddering attacks frequently considered or misdiagnosis as epilepsy, and this is well determined or noted in the study, in a Turkish study, about 19 cases of shuddering attacks. And in this study, they noted that about 58% of the patients were evaluated with the preliminary diagnosis of epilepsy. And the situation can be more difficult if in this shuddering attacks attacks, patient also can have also epilepsy, and this make the diagnosis very more difficult, and the distinction between another type of event and refractory epilepsy very difficult. Also, we can have some abnormal movement, ocular abnormal movement, who can be misdiagnosed as epilepsy. This is the case of these children, referred to our department with the diagnosis of absence epilepsy. And as we say, EEG video for these two children are normal during the event, and we can exclude the diagnosis of epileptic absence epilepsy, and to retain the diagnosis of paroxysmal tonic upgaze, which is defined as a conjugate upward deviation of the age lasting between 2 or 30 seconds, and these attacks can onset insidious, but also can be triggered by intercurrent illness or fever. And in general, this paroxysmal tonic upgaze occur in children, normal children with normal development, but recently we described that we can also have in these children developmental delay, and also in some case we can have association with ataxia, and we need to be more careful and to examine carefully these children. And beside this movement, we have several other movements, benign movement disorder in childhood, such as sleep-related rhythmic movement or gratification behavior, which the diagnosis can be easier, because with the normal developmental and the normal interictal exam. But in some case, movement can be more difficult to distinguish between epileptic movement, epileptic abnormal movement, and non-epileptic abnormal movement. And this is the example of this young baby, 8 months old girl. And she was referred in our department because she started to present nodding. She has a normal development and normal motor and cognitive development, and normal exam without any neurological or somatic sign. And in the EEG and the EEG video, you can observe this movement who occur in cluster. This nodding, this is the first attack. So this movement and repeat occur in cluster, and in this situation the diagnostic with epileptic spasm or atonic seizure can be really very difficult if we don't have EEG video, and if only have the clinical the history or the description of the movement by the parent. But here we can be sure that this movement is not epileptic movement, because the EEG, we cannot see any EEG epileptiform abnormality in the EEG. And now this baby has 4 years and she is very well without any abnormal movement at this moment. This group of movement are gathered by Fernandez Alvarez in 2018 and described as a benign polymorphism movement disorder of infancy. And this paroxysmal event during occur in cluster. and with a short duration without alteration of consciousness, and repeated several times per day, usually triggered by excitement with normal developmental exam, neurological exam and EEG examination, and usually disappear before the age of 2. And these movements can be of different type, like fine or coarse tremor, tonic contraction, atonic or negative myoclonic or shaken body. And in some infant, we can have association of several type of these movement. This is another type of movement. Also, this baby was referred to our department for the refractory tonic epilepsy, and we see that in the EEG video, this tonic movement are not epileptic movement. This is, now we can move for a more complex situation when in the same family or in the same patient, we can have the coexistence of movement disorder and epilepsy, and the diagnosis between them. It can be very difficult and can need more technical and more careful exam. And I will start with the autoimmune encephalitis. And as you know, autoimmune encephalitis is characterized by cognitive and behavior abnormality, and also movement disorder and seizure, or frequently, example, seizure is present in 100% in the ILAE, G and Col study, and the movement disorder in up to 89% of cases. This situation is the misdiagnosis is frequent in this situation, especially in two type of autoimmune encephalopathy, the NMDA encephalopathy with the oral facial dyskinesia, which usually are misdiagnosis as focal motor epileptic seizure in this child with a very bad and very bad neurological situation. The misdiagnosis can be easy, and we need to be careful and to have in our mind this possibility. Also in encephalitis, anti-LG1 encephalitis, the paroxysmal brachiofacial dystonia can be misdiagnosed as focal epilepsy, focal epileptic seizure. And here the EEG, the critical EEG of this movement can correct the diagnosis of abnormal movement and not refractory epilepsy, because in this situation, child or the person has already epilepsy, but this movement are not epileptic seizure. So we don't need to increase the anti-medical seizure for this patient if we are sure about the diagnosis. Another situation is a very difficult situation in the children with neurodevelopmental disorder, when the stereotype movement are very frequent. And stereotype movement are defined as a repetitive rhythmic movement, and these stereotype movement are frequent in these children, especially in children with autism spectrum. And the distinction and the diagnosis of epilepsy or no epileptic movement abnormality or event is frequently very difficult. And this situation, this movement are frequently responsible of false positive with misdiagnosis of epilepsy and in front of this abnormal movement. And also this movement can lead to a false negative and responsible for a late diagnosis of epilepsy. And this situation is very very difficult if we know that exploration and EEG, to have EEG for these children who usually are very hyperactive and very difficult to have EEG. Its situation can be really very difficult, and we need to be patient and to be patient and in order to make the right diagnosis. This is the example of one child, 4-year-old girl. She has a delay of motor and cognitive development, and at the age of 15 months, she began to have abnormal movement, a stereotypic movement. It's rocking off the trunk, and the diagnosis of severe intellectual disability deficiency with stereotypy was made. But the mother was not convinced by this diagnosis, because they noted that her child has two types of movement. Beside the stereotypy of the trunk, they described another type of movement, and EEG video confirmed the depth of the mother and show that beside the stereotypy, the child also have epileptic spasm. Can see here, but we need to see very here it's epileptic, very beautiful epileptic spasm confirmed by a typical pattern of epileptic spasm in the EEG. And this child, between the age of 15 months for it, we have a delay of about 2 years for the diagnosis of epileptic spasm. Also, the child with motor deficiency can also have some difficulty to have a right diagnosis. And the more frequent example is the starter movement in children with spastic cerebral palsy. And this is the example of this child who has a spastic bilateral cerebral palsy with epilepsy, and this child was treated by several anti-seizure medication, and the mother usually come back to the outpatient and say that this child, her child or have more and more epileptic seizure. But in the EEG video, we see that this movement, this tonic movement here in this video are not coupled with Eeg abnormality. And if you look at the video, we see that the mother stimulate the child, and the tonic movement is followed cutaneous stimulation by the mother, and confirm that these movements are not an epileptic seizure, and lead us to diminish the number of anti-seizure medication. Another very good example of the association of and the difficulty of the diagnosis between epileptic and non-epileptic movement disorder is the group of developmental epileptic encephalopathy, which are an heterogeneous group of severe epilepsy with developmental delay and mainly caused by genetic mutation. And movement disorder in this group of disease are very frequent and polymorph, and we have mainly the hyperkinetic movement disorder. Also, this movement disorder appear very early and in some time before epilepsy, and also persist after disappearance of seizure. And this movement disorder can be responsible of false refractory epilepsy, like the precedent example. And here we need to really to have a very strong EEG coupled with the EEG and EMG, and in some case we needed to have more electrophysiology technique in order to have the right diagnosis. This is an example of a child with 7 months. He was followed with the diagnosis of referred with the diagnosis of epileptic spasm with ipsarrhythmia. He was treated with vigabatrin, and during his hospitalization, we noted that the EEG become improved. We have improvement of the EEG with the diminution of the epileptic spasm. But the mother, when we asked the mother, she usually said that her child have more and more seizure. And here you see that the child have this abnormal movement, but mainly this rhythmic movement in the foot, continuous rhythmic movement, clonic or myoclonic, and the EEG coupled with EMG can confirm the diagnostic of non-epileptic myoclonics and confirm that we don't need to increase the treatment, the dose or the level of anti-seizure medication. This is another example with a child with developmental epileptic encephalopathy. She had epileptic spasm and also focal epileptic seizure. And the mother come in the outpatient, say that her child has another type of seizure and need more treatment. And as you see that this blinking of the eyelid is not, this movement was not confirmed as an epileptic spasm in the EEG. And abnormal movement can be the coexistence of epilepsy and movement disorder in developmental epileptic encephalopathy can increase the difficulty of the right diagnosis, but also they have some advantage. Indeed, the presence and the existence of abnormal movement in this group can give the genetic study. And several studies showed that the level or the rate of positive genetic mutation or higher in a group with abnormal movement, and especially in early onset epileptic encephalopathy, where the level of the positive rate of mutation is up to 80% of cases. And in some cases, abnormal movement can help to better and to accurate genetic diagnosis. Example, dystonia can lead us to look after IRX mutation rate like phenotype CDKL5 and FOXG1 mutation, and also choreoballistic movement also lead to look after STB1 mutation. And this is an example of the study of a systemic review made by Spagnoli, Carlotta, about 49 study, and they noted that the main seizure type at the onset can be focal, tonic, epileptic spasm, myoclonic, tonic, or tonic colonic seizure and multifocal seizure. And also the status epilepticus is reported with SLA 13A5 and focal tonic-clonic with dysautonomic feature reported for KCQ2-related encephalopathy. And that hypotonia is the main clinical symptom, and the age of onset of movement disorder is variable, and the type of movement disorder is also different according to the age of onset. Example, for the neonatal age of onset, the main type of movement disorder is myoclonia and tremor. For infantile is excessive starter and focal dystonia. For children between 1 to 3 years, hypokinesia, and for adolescents is Parkinsonism. Here's some example and the relation of movement, the movement disorder, and also the type of gene. Another group of who can have the coexistence of the association of epilepsy and paroxysmal movement disorder is the group of paroxysmal dyskinesia, which is an heterogeneous group of disorder characterized by intermittent episode of involuntary movement. And this group are divided into two groups according to the etiology: secondary paroxysmal dyskinesia and primary or genetic paroxysmal dyskinesia. And in this talk, I will focus in the primary or idiopathic or genetic paroxysmal dyskinesia. In this case, familial case is observed in 40 to 70%, but we can have also sporadic case. And in this, in the same patient, and even in the same family, and even in the same patient, we can have epilepsy, migraine, and ataxia, and also paroxysmal dyskinesia. And this situation can be really very difficult, especially in children in the young age. And this is an example of this difficulty. Here she's 24 years, but I followed her since the age of 4 years. She has a personal simple febrile seizure history and language delay. She has also familial history of severe intellectual disability. And at the age of 4 years, she began to have a left focal motor epileptic seizure with a focal centrotemporal discharge in right focal temporal discharge in the EEG. And at this moment, the diagnosis of epilepsy with centrotemporal spike was made, and the children was treated by Valproate with a good evolution. But at the age of 6 years, she started to have an abnormal movement in the left hand, the same arm. And at this moment, we thought that we make a misdiagnosis of epilepsy, and we thought that this movement or abnormal movement and not epileptic seizure, especially that the EEG was not very the discharge or were not very abundant. And we stopped the Valproate, and she developed the focal status epilepticus. And then we, with the aggravation of the EEG, and then we restart treatment with carbamazepine. Till now, they didn't have epileptic seizure, but till now she has this abnormal movement in the same, with a severe delay of language, in the same arm, in the left arm. And till now, we cannot determine if this abnormal, if this is epileptic or non-epileptic movement disorder. And in the EEG, we cannot be sure that this discharge or epileptiform discharge and the focal discharge. And unfortunately, we don't have a genetic study till now. So this primary paroxysmal dyskinesia are divided in three mainly groups. The first group is called the paroxysmal kinetic dyskinesia, triggered by voluntary movement. The movement duration lasts less than 1 minute, and with a good response to anti-epileptic drug, especially carbamazepine, and several genes were described, but the most frequent one is the PRR2T2. The second group is the paroxysmal nonconcentric dyskinesia. The movement triggered by alcohol or coffee. It lasts more than 10 to 1 hour, but less than 4 hours, and this movement have a good response to benzodiazepine. And the main genetic mutation is MRI1. And the third group of paroxysmal dyskinesia is triggered by sustained exercise. It lasts 5 to 30 minutes, and they have a few attacks per year. And in this group, treatment with anti-seizure medication is not very, is not very useful. And the most frequent mutation is SLC2A1, which is for GLUT1 deficiency. And here it's to show you the phenotypical overlap for gene between paroxysmal dyskinesia, epilepsy, and migraine. And we have several genes described in epilepsy and paroxysmal dyskinesia or in migraine. And I will finish with this example, and to stress that abnormal movement in people with epilepsy can be also provoked or triggered by anti-seizure medication. And we know that Valproate and vigabatrin can lead to the occurrence of abnormal movement, and also some other treatment. And this is the example of this boy. He has focal epilepsy. He was treated by lamotrigine, but with a high dose, 10 milligram per kilogram per day, and he was referred to our department for refractory epilepsy because they have this abnormal A movement considered as epileptic seizure by his doctor, and the EEG showed that this opsoclonus myoclonus are not. It is not epileptic movement with a normal, very normal EEG. And the diminution of the level of lamotrigine lead to the disappearance of this movement. So I finished my talk. I hope that I give you some example and convention you that about the difficulty to make the distinction between epileptic and no epilepsy seizure, and the need to have more accurate diagnostic and a more accurate definition in order to avoid a misdiagnosis of epilepsy. And thank you very much for your attention.
Thank you very much, Professor Tricky, for a wonderful, wonderful presentation, quite comprehensive, very good approach, and very enlightening as well. There have been some few questions trickling slowly. I'm sure there'll be more coming through the Q&A. And just to remind people, don't forget to put your questions on the Q&A. Maybe we can start with the first question before I ask for some comments and from Professor Bensassi and Professor Ahamdi. John asked, this is probably specifically for you, Professor Tricky. John asks, what software do you use for back averaging in your lab?
Oh, yes. Unfortunately, we don't do this technique. It is we work together with neurophysiology department, and they did this technique, but we cannot do it in our child neurology department. But we work really very together. But perhaps Professor Samia Ben-Sesi can give us the
there
answer.
are several, yeah, there are several software such as coherent software, but in fact, recently there is a free online platform for back averaging. It's called BackAv. So you can use it, it's free and it's online. Maybe
Thank you,
write,
Samia. Yeah.
write the name of the platform on the discussion. So it's called BackAv.
Yeah.
Okay.
Thank you. Thank you. Thank you very much, Samia. The second question, Professor Tiki, is that someone is asking in shuddering attacks. You've shown a nice video there. They're asking whether one should do an EEG or not.
Absolutely not. Absolutely. This is the aim of this presentation.
Yes,
Is
yeah.
don't ask for EG.
So if you've seen it, if you've seen one, you've seen a few, then you've seen them,
Yes.
and then you know. Yeah,
Yeah.
and that's the whole point. Good.
But
correct.
really, we need to have the EG, the video, the home video,
Yeah.
and it's we needed to ask the mother to record their child and to give us the video. It's very important, and not to treat it as an epilepsy very quickly. We needed to calm down and to think about this movement and to have video before to start the treatment and before to ask for EG.
I always tell my students that the video must also be accompanied by a story. You know, the video alone sometimes out of context, you know, is not complete. And so the story and the video, that's complete.
Absolutely,
Yeah.
absolutely.
The next question is, not sure whether I understand the wording correctly, but they say, what is the rhythm or to repeat an EEG if the first was normal for a child with a movement disorder and developmental delay? Not sure whether they're asking an indication to repeat an EEG. They say to repeat an EEG after the first was normal for a child with a movement disorder and developmental delay. And they say they see a lot of these scenarios where there's a child with a movement disorder and developmental delay, and the first EEG is, they're not sure of the movement, whether it's epileptic or not. And I suppose the first EEG is normal. So do you need to repeat and chase, or?
In some cases,
yeah.
If the child has an epilepsy, yes, we needed to do another EEG in order to be sure that it is really another type of seizure, or the seizure become refractory. But if the child or not now as has epilepsy, I think we needed to look carefully in the clinical. We needed to have a very good clinical examination and to see the movement in order to be sure and to distinguish abnormal movement from epileptic movement. In several cases, we can in clinical examination we can distinguish epileptic movement and abnormal movement, and so it's a case by case. Really, we don't. I think we don't have rules in when to do and how many EEG we need in order to have a right diagnosis.
It's very difficult, isn't it, when the event is not happening at the time and you do an EEG in between, and it doesn't mean anything, except if you capture it on video EEG, then wow, you got an answer suddenly.
In general, for the child with neurodevelopment disorder, movement disorder are frequent. So if we did the long EEG, a 24-hour EEG, we can catch the abnormal movement.
Yes. The other thing that helps sometimes, if it's just an EEG in between, sleep EEG tends to be much more productive than an awake EEG. Any comments,
Yes.
Professor Ahadi?
Yes, sir. I just totally agree with you. So what we are doing for those patients, especially, I mean, if we are doubt that this is not a seizure, so the best way, yes, exactly, to admit him for the epilepsy monitoring unit, admit him for a couple of days even, and try to find this movement. But really, the big challenge will happen if these events is not that frequent. So this is really, it will be difficult for us.
The opposite of that, this is my question before I go to the next question, Professor Tricky. You've probably all seen, we all look after Rett syndrome patients. And sometimes even they've got movements that are very difficult to distinguish, whether it's movement or, you know, beyond the hand wringing and all of that. Sometimes there are some odd movements and you're not sure whether it's tonic seizure or it's, but the interesting thing is that even before the clinical seizures start, the EEG sometimes is abnormal already. So that becomes tricky sometimes to interpret. And that's the opposite of the question that's just been asked. You know, sometimes it's very difficult. There is a propensity or potential to develop epilepsy, but sometimes even before the clinical seizures start, the EEG may look abnormal with some of the Rett syndrome. Has that been your experience?
Sorry, but the sound is not very clear.
For the Rett syndrome, for the Rett syndrome,
yes,
yes, yeah. I was just saying, or asking, do you have the experience of having them? Sometimes the EEG is abnormal before the seizures commence, and so sometimes it's difficult to interpret the abnormal movements in that context. Yeah.
No, we don't have the experience to have abnormal EEG because we don't ask for EEG before the beginning of epilepsy in Rett syndrome. And in general, the movement of the abnormal movement in Rett syndrome is typical. It's with the washing movement, etc. And it's really the diagnosis with epileptic movement, abnormal movement is easy in general. If
beyond the stereotypies, you don't often see some odd movements in the
stereotypy Rett syndrome.
Besides the stereotypies,
usually the abnormal movement usually are different.
Yeah.
We have a movement for the hand movement with the washing movement, and really we can make the distinction between epilepsy movement disorder and the stereotypy for Rett syndrome. But we never ask for EEG before the beginning or the start of epilepsy, not like the tuberous sclerosis. Not like. Perhaps we needed to do some experience, but we don't ask in our department.
Samia?
Regarding stereotypies, I think very important to determine the phenomenology of the movement disorder. It's also an important clue is the distractibility we have in the case of stereotypy, which we don't see in seizures. So it's important to look for the distractibility besides, of course, EEG recording.
Yes, stereotypical. I mean, they are very easy to define and stereotypical, as the name says. Yeah. The next question is
Can I ask Dr. Ramgi if they ask for EEG for Rett syndrome before the start of epilepsy?
Yes, no, totally agree with you. Usually we are not like doing that for Rett syndrome. Yes, we are doing the same things. If they start, I mean, if the movement is very clear for the Rett syndrome, so it's fine. Then if we start to have the seizure or things not going with the stereotypies of Rett syndrome, then yes, we'll go for it.
Yeah. Yes. Completely agree. The next question is, in cases of hyperexplexia in a child who does not respond to clonazepam or valproate, what other drugs can be used and be helpful? And that's a question from Niba. Anybody? Yeah. In hyperexplexia, the status.
Yes.
Yes.
I don't know. Okay, please.
Yes, please go.
No, I mean, for us, like with the hyperexplexia, yes. I mean, we're trying with the benzos, with the clonazepam, and to be chosen for that. So this is one of the choices usually we are trying to get it. And the very important things also, as we said, we need to be sure, is it really hyperexplexia or we are dealing with something different, like it could be myoclonic seizures. So I don't know.
So
Obviously,
in
also,
hyperexplexia,
carry on, Samia.
so in hyperexplexia, we consider that it's a sort of myoclonus, and it's an actual myoclonus type. And the generator is not cortical; it's subcortical. It's within the brainstem, so it's not. It does not respond to anti-epileptic drugs. The only efficient drug is mainly the clonazepam. We can also use the 5-HPT, which can be useful, but mainly it responds to clonazepam because it's subcortical. So when the generator is not cortical, when myoclonus have a cortical generator, it can respond to anti-epileptic drug, Valproate, levetiracetam, etc. But when it's subcortical, it's not the case, such as in hyperplexia.
Yeah. We also tend to use clonazepam, and we completely agree with the rest of your comments. So the other one is what treatment for tremblement associated with child epilepsy can we use captopril? Not sure about that question. Asking if someone can use captopril for someone with epilepsy and tremblement. Suppose that's tremors or something. I don't know.
I
want to skip that one.
What is the treatment? Sorry.
They want to find out if one can use captopril, which is a ACE inhibitor for tremor or tremblement in childhood epilepsy.
Perhaps Dr. Hamdi or Bensisi can.
Anybody has heard of that?
I have no idea really.
No, I'm not sure either. I'm not sure either. The others are comments that are very complimentary and brilliant talk. And then the follow up on the original question about back averaging. In what cases can one send for back averaging? Can you
if you are
provide
not
with
sure,
links?
it's
Someone's
to
asking
have the
for-
diagnosis. Yes, sorry.
Someone is asking what cases can one send for back averaging?
When we are not sure about the origin of myoclonia, and we need to confirm that myoclonia has a cortical origin. This is for us the mainly indication for us, especially for the developmental epileptic abnormality, because in developmental encephalopathy and epilepsy, abnormal movement is frequent, and myoclonia is the most frequent movement, abnormal movement we have. And we need to distinguish between the increase or the appearance of a new epileptic seizure, or it is non-cortical and non-epileptic myoclonia. This is the main indication for us to ask for this technology.
Thanks, Professor Trigi. I'll move on to the next one. They are coming through now. In aggressive movement disorder in NMDA encephalitis, what drugs you advise to use other than benzodiazepines?
For us, it's the treatment for epileptic encephalitis, for the autoimmune encephalitis and the movement disorder, especially for NMDA, disappear in a few days. They don't last a long time, but this is our experience in our department. It's
yeah. I don't know what Samia may want to say, but my feeling is you treat the immune process. So the immunomodulation, doesn't matter how big drugs you can use, lots and lots of drugs, but if you don't address the cause, and they are very sensitive, if you give the IVIG, the steroids, and they tend to abate.
Yes.
Early and aggressive treatments. Yeah.
I do agree. I think it's not about symptomatic treatment of movement disorder, but it's a pathogenic treatment using steroids and
precision medicine. Yeah.
Yeah.
All right. The next one is in a case of interictal EEG abnormalities, but with no movement recorded during the EEG, shall we treat the patient or repeat EEG until catching the movement?
No, it's it's a very difficult question. I really, when we have abnormality in EEG without abnormal movement, we have another type of problem and another type.
One exception, Professor Chiki,
Yes.
the epileptic acquired aphasias, Landau-Kleffner, you know.
Yes,
the
yes,
sleep EEG.
no.
That one is an emergency. That's a different
Yes.
one. Yeah, that you
Yes,
treat.
in the slow wave, continuous slow wave
yes,
during
yeah.
sleep. Yes, okay.
Yeah.
But in other, in some cases, in normal children and also children with autism spectrum, we can have EEG abnormality. And the discussion, shall we treat, shall we not treat? And we don't have an answer. So it's a case by case.
Yes, yeah.
So if we have, in general, if you have behavior abnormality or language abnormality, yes, we need to treat.
Definitely, yeah.
If
Especially
not,
speech
we
and
don't
cognitive
need to
decline.
treat.
Yeah, all right. The next one is same diagnosis were evocated in MD appeared in older people. I'm not sure what the question is about. I suppose they are asking whether the same diagnosis also seen in older people, in children, I suppose. Yeah.
I'm not sure, Dr. Semia, possible can answer you because I'm child neurologist.
I'm an adult neurologist, so what we see more than genetic forms, primary forms of paroxysmal dyskinesia, we'll see secondary forms, so secondary to autoimmune diseases such as NMDA or LGI1, or metabolic and iatrogenic causes of paroxysmal movement disorder. So it's much more frequent than the primary causes which occurs earlier in life. So we need to always think when we have a sort of paroxysmal movement disorder of the curable causes, the autoimmune causes, the vascular, the tumoral causes, and the iatrogenic causes also, such in the case, for example, for the case Dr. Shanetriki showed of the paroxysmal tonic upgaze. We need to think also about the iatrogenic causes, for instance, the intake of hidden neuroleptics. So it's very important to look for such curable causes, and they are more frequent in the adult population.
But also the LG1 encephalitis was now we have a description with the child from Saudi Arabia with Professor Raida Al-Baradei. She reported one child with LG1 encephalitis.
So the typical pattern is paroxysmal
is for adult
of the upper limb dystonia. It's very it's an important clue for the diagnosis.
Absolutely.
The interesting thing is that in children, as they grow older, with the same gene, with the same disease, they will change the manifestation, even with movement. Often they are hyperkinetic when they are young, and when they are older, they can get hypokinetic with some of the genetic disorders.
Absolutely.
So it evolves with time. Same disease, same. That's why it's important, and not to just say when you're asking family history, anyone with the same thing, because the adult may be showing something completely different, but same gene and same disease process. That's very interesting. You know?
Yes, absolutely.
And just to add, Professor Tiki, on your point about the videos and the genes, but I think as much as we getting genes and we doing next generation sequencing, I think the phenotypic description is still very critical, because sometimes you get variants of unknown significance when the genetic results come back.
Absolutely.
And so the clinical phenotyping is still very important. People must not just see someone and just send for genetic sequencing straight up.
Yes.
I think you need to describe
Absolutely.
and describe. Yeah. It looks like yes, you were going to say?
Yes, the most difficult part of the genetic study is the interpretation of the result. So we need the cooperation between clinician and genetician. So yes, I agree with you.
I'm going to wrap up now and ask for last comments from everyone because the questions have subsided.
Dr. Ramdi, please.
Yes, just agree with you. Like now, especially in our country, that like we have like the high consanguinity rate. So we are seeing a lot of cases with genetic disease. So sometimes, yes, if we face like variant of uncertain significance, it will be really a big challenge. Sometimes, you know, with the common, like the GLOT1 deficiency, you know, now the spectrum is increasing. Now they can present with movement disorders, not clear a picture of seizures. They can have ataxia. So sometimes, yes, this is a really big challenges for us. Just one, like maybe just taking your opinion with that, like exactly patient who's suffering from brain hypoxia, then he's having subcortical myoclonus. I know it's one of the like kind of difficult treatment, but maybe just I need to hear from you, like what is your experience with which medication can work for it?
So
subcortical, non-epileptic.
Yeah, so
non-epileptic, yes.
In Lanzarote, it's post-anoxic.
Yes, post-anoxic.
So
yes.
In post-anoxic, usually we can have both components. We can have cortical and subcortical myoclonus. And so it's important in Lanzarote cases to treat with clonazepam, but we can also use anti-epileptic drug because usually they are also a cortical besides subcortical component. So we can use Valproate or levetiracetam. You can associate both levetiracetam with the clonazepam. And we can keep the patient even a long period under clonazepam. Usually it's well tolerated and rather efficient.
There's an old drug, it used to be called piracetam. So levetiracetam is a newer generation of that, and they work against myoclonus quite well.
Yeah, but with piracetam, we need very high doses, up to 24 grams per day. With levetiracetam, we use smaller doses. That's why we use rather levetiracetam rather than piracetam.
Yeah, it's difficult to get piracetam.
Yeah.
Yes.
Everybody, the panel, I don't know if that looks like there are no further questions except to thank you very much, Professor Tiki, for a wonderful talk, starting from basic and going beyond to genes. The next chapter will probably be investigation and management of the same talk. That would be nice to talk about precision medicine and specific treatments and management diagnosis. Thank you, everybody, for a wonderful evening.
Thank you.
And yeah.
Thank you. Goodbye.
So everybody that's there, there'll be some advertisements for future meetings and things, and just be on the lookout on the screen. Thank you very much. Bye-bye.
Thank you.